just to kick-start the session, we're going to have Dr. Judith Askew, who is Intensive Care Fellow from the Royal Prince Alfred Hospital in Sydney, Australia. She'll be sharing with us today on the asthma in the ICU. Just to let you know that the questions and answers will be arranged at the end of all three sessions, and after which we'll just have a light-hearted discussion, and I hope you enjoy the sessions ahead. Judith, take it away. Yeah.
Thank you. All right. Good morning, everyone, or evening for anyone in Australia. My name is Judith Askew. I'm one of the Intensive Care Fellows at RPA Hospital in Sydney, Australia. Today I'm going to be speaking about asthma in intensive care in place of Ross Freeburn, who unfortunately is stuck in Samoa dealing with the measles crisis. So some local numbers to start off with. In Australia, we've got 1 out of 10 people suffering from asthma, and we had nearly 40,000 hospitalisations in 2011 to 12 due to asthma. Nearly 400 deaths in 2011, compared to less than half of that in 1989. 10% of the patients we admit to hospital with asthma will go to intensive care, and of those, about a third require mechanical ventilation. This is a graph from the WHO which illustrates what I just said in regards to the reduction in death rates related to acute asthma. So the dark blue numbers are a 5-year period from 2001 to 2005, and the light blue numbers a 5-year period 10 years later. And it shows that in both high and low income countries, the death rates from acute asthma have reduced over that decade. The basic pathophysiology of asthma, as we all know, involves acute inflammation and edema of the respiratory epithelium, mucus obstruction and sloughing of the epithelium. This leads to acute small airways obstruction and airflow limitation. The picture on the left demonstrates a normal bronchus with normal airflow, whilst the one on the right is thickened and edematous, with consequent reduction in airflow, as we see in acute asthma. This leads to mainly expiratory obstruction. So during inspiration, the lung expands, pulling open all the components, including the airways. In expiration, the opposite occurs, particularly end expiration, and you end up with airways obstruction. And this leads to lung distention. In non-mechanically ventilated patients, the lung overdistension that we see in acute asthma causes an abnormal shape of the hyperexpanded thorax, which interferes with respiratory muscle function. Muscles are therefore less efficient. We need more muscle power to distend the lung, and compliance worsens. And more ventilation is required to keep the PaCO2 normal, resulting in an increase in dead space. The increase in airways resistance seen in asthma due to bronchoconstriction, edema and mucus, the presence of dynamic hyperinflation and increased elastic recall all contribute to an increase in inspiratory work. Expiration, which is normally passive, becomes active as greater effort is required to empty the inspired volume through the resistant airways. Hence, work of breathing increases and the patient fatigues. In the mechanically ventilated patient, the effects of lung overdistension are slightly different. Hyperventilation leads to mild to moderate hypoxia, and there's usually only minor shunt. Severe hypoxia is usually only associated with decompensation or with associated complications such as atelectasis or pneumonia. However, gas trapping becomes a significant issue in the mechanically ventilated patient. Gas trapping, dynamic hyperinflation, auto-PEEP or intrinsic PEEP. They're all words for the same effect, which is an increase in lung volume due to the increase in airways resistance. This causes a reduction in flow rates, meaning that expiration time is prolonged. If inspiration begins prior to complete exhalation of the preceding breath, then gas trapping occurs. This causes an increase in lung volume and pushes the lung to a less favourable point on the compliance curve, requiring greater pressure to produce a given change in volume. Hyperinflation can be beneficial in that greater lung volumes increase airway diameter and lung elastic recall to improve expiratory flow. However, it can also contribute to morbidity via barotrauma and cardiovascular compromise. The increase in intrathoracic pressure associated with lung overdistension causes a reduction in venous return and therefore a reduction in cardiac output. In 1744, John Fothergill noted that mouth-to-mouth ventilation was superior to using the bellows for resuscitation because it reduced the risk of hyperinflation. Progressive hyperinflation leads to barotrauma, causing pneumothorax, pneumomediastinum, and other injuries. Plateau pressure, but not peak inspiratory pressure, has been shown to be related to the risk of barotrauma, such as this pneumothorax. So how to treat? Asthma cigarettes are out, bronchodilators and steroids are in. Non-invasive ventilation is controversial, and invasive ventilation can be difficult. A Cochrane review in 2012 concluded that the preliminary evidence regarding non-invasive ventilation in asthma was positive, but that large-scale trials were still needed. In a patient without contraindications, it's feasible to trial non-invasive ventilation. A reasonable approach is to commence with a PEEP of 0 to 5 centimetres of water and an IPAP of 7 to 15, titrating to a respiratory rate of less than 25 and patient comfort. High-flow nasal cannulae are another emerging treatment. They work via a number of mechanisms. A reduction in anatomical dead space by flushing the upper airway with humidified fresh gas. A small degree of positive airway pressure, depending on the flows applied. A consistent concentration of inspired gas, from 21 to 100%, and delivery of appropriate humidification, which aids ciliary clearance. The high gas flows ensure that the vast majority of inspired gas is from the device, and little, if any, is entrained from the environment. What this means in regards to asthma therapy is that if a nebulizer mask is used over the top of the high-flow device, the gas flows from the high-flow nasal cannulae will prevent the nebulized gas flow from reaching the airway, and thus only a negligible amount of the nebulized drug will be inhaled. So if administering nebulized medication to an asthmatic patient on high-flow nasal cannulae, you either need to stop or disconnect the high flow during therapy or use an adapter to deliver the medication directly into the high-flow nasal prongs as the driving gas. Invasive ventilation, when to tube. Intubation should be considered if the patient becomes exhausted, if there's a deterioration in mental state, hemodynamic instability, severe hypoxemia, or severe acidosis or hypercapnia. Remembering that in the asthmatic patient, normalisation of a previously low PaCO2 is also a significant warning sign of fatigue. The next question, pressure or volume ventilation. There are no controlled studies to support the superior of any mode over the other. Use what you're familiar with. Pressure modes limit the airway pressures applied, providing a safety factor, but provide a variable tidal volume depending on airways resistance and lung compliance. This means that you get variable tidal volume, variable CO2 clearance, and variable bronchodilator delivery. Controlling the tidal volume, such as in assist control or SIMV with volume control, ensures consistent alveolar ventilation. And with modern ventilators, monitoring the pressure required is easy. The aims of invasive ventilation. Number 1, oxygenation. Number 2, avoid dynamic hyperinflation. Do this with a low minute ventilation strategy, low tidal volume and respiratory rate, with permissive hypercapnia, so accept a PaCO2 of less than 90 as long as your pH is over 7.2, and aim for intrinsic PEEP of less than 10 centimetres of water. Reduce barotrauma by aiming for plateau pressures of less than 30. Reasonable parameters to start off with include a tidal volume of 6 to 8 mils per kilo, a rest rate of 8 to 10, and a PEEP of 0 to 5. Use a long expiratory time with an I to E ratio of at least 1 to 3 to 1 to 4, and start with an FiO2 of 1 and then titrate down. This diagram demonstrates the concepts of peak and plateau pressures. Airway pressure is based on two components, the baseline or alveolar pressure and the pressure required to inflate the lung. The alveolar pressure, letter B on this diagram, is dependent on volume, compliance, and PEEP. The total airway pressure, letter A, is dependent on flow times resistance plus alveolar pressure. So the PEEP pressures are those required to overcome the flow and resistance of the airway and inflate the lung. Plateau pressures are those in the alveolus in the absence of flow, such as during an inspiratory hold. And this is nicely demonstrated here, with a very high peak pressure of 91 required to push air into these bronchoconstricted asthmatic lungs, but a much more reasonable plateau pressure of less than a third of that. The reason we want to avoid high plateau pressures is the risk of barotrauma. Auto-PEEP can be assessed clinically by looking for an increase in patient effort, reduction in efficacy of ventilation, hyperinflation on imaging, or hemodynamic compromise. Ventilator manoeuvres we can assess are an end inspiratory hold, which will demonstrate the plateau pressure, and a rising plateau pressure in the absence of any changes in ventilator settings suggests auto-PEEP. Flow time curves are useful in showing whether flow returns to zero prior to commencement of the next breath. You can also quantify auto-PEEP by doing an end expiratory hold, which allows for quantitative assessment of alveolar pressure above the extrinsic PEEP. There are lots of adjuncts that can be used in the management of acute asthma, and to go into the medications used is beyond the scope of this talk. But suffice to say that adequate sedation plus or minus paralysis will be necessary to improve patient ventilator asynchrony, to suppress the respiratory drive associated with acidosis and hypercapnia, and to reduce oxygen consumption and CO2 production. Other things to think about when facilitating mechanical ventilation: heavy sedation and paralysis, as I mentioned, watching for lobar and segmental collapse, adequate humidification with a wet circuit right from the start, and have a high suspicion and early treatment of ventilator-associated pneumonia. Number of things to troubleshoot in the asthmatic patient who's being mechanically ventilated. If you suspect dynamic hyperinflation with plateau pressures of over 30 or an auto-PEEP of more than 10 to 15 centimetres, reduce the extrinsic PEEP, increase the expiratory time, and reduce airways resistance. The use of heliox is controversial. It decreases gas density and reduces resistance during turbulent flow. It may improve dyspnea pre-intubation. However, there's no outcome data in ventilated patients with severe asthma or COPD. It's expensive, and the use of heliox means that your oxygen concentration delivery is limited. If you have issues with oxygenation, do the simple things. Increase the FiO2, get a lung ultrasound to check for the presence of barotrauma, such as pneumothorax, get a chest X-ray to check the endotracheal tube position, and consider adding PEEP cautiously. With worsening hypercapnia or acidemia, gently up-titrate the minute ventilation, monitoring for dynamic hyperinflation. The use of sodium bicarbonate is controversial. When weaning ventilation in the acute asthmatic, typically at least 24 to 48 hours ventilation is required. Asthmatics tend to wean more quickly than the COPD patients. Look for evidence of significant improvement in dynamic hyperinflation, so an auto-PEEP of less than 5, resolution of wheeze, and improvement in PaCO2 and pH. Trial the patient on pressure support, with or without PEEP. Extubation onto non-invasive ventilation has not been well investigated in asthmatics, although there are some good results in COPD patients. Overall, none of the ventilation strategies mentioned here have a strict evidence base, but mortality is declining. The key goal of controlled mechanical ventilation in the acute asthmatic patient is to prevent dynamic hyperinflation. Prolong the expiratory phase as much as possible. Minimise tidal volume and use zero or low PEEP. Tolerate hypercapnia with permissive hypoventilation if necessary. And above all, have patience, continuous reassessment and attention to detail. Thank you very much for your time. I'd like to thank Ross Freeburn for the use of some of his slides, and I think actually we're taking questions at the end.
Okay. Thank you, Judith. That was an excellent talk. I really enjoyed it very much. And so moving on, we will be inviting Dr. Tommaso Mori from the University of Milan to talk to us about how to ventilate a patient with COPD exacerbation, two seemingly similar diseases, but actually perhaps still some subtle differences in pathophysiology. Dr. Tommaso, I think, did his research fellowship in Massachusetts General Hospital in Boston, and currently is a staff physician at the Department of Anesthesia for Transplants and Critical Care at the University of Milan, and he has published extensively in peer-reviewed journals and then authored chapters in many books on critical care topics such as respiratory physiology, mechanical ventilation, electrical impedance tomography, cardiac arrest, infection, and ECMO. So without much further ado, let's bring Dr. Tommaso on board. Tommaso, please. Yeah.
Thank you. Here is a nice morning in Milan. Good morning to all. So I'll try to share my slides. Let me know if this works. Can you see my slides?
Yeah.
Oh, yeah, there we go.
Okay, so how to ventilate a patient with an acute severe COPD exacerbation? I was asked. Thanks for the invitation. I think this is a very nice and wide and inclusive initiative that I like a lot. These are my conflict of interest, which are not really related to the talk, but it's always useful to show in the beginning. So the pathophysiology for COPD is kind of similar to the one that Judy just explained on asthma, with some peculiarities due to the fact that it's a chronic condition and not just an acute condition. However, if we need to intubate and ventilate a patient, the chronic overlaps with some acute that makes it worse. The chronic process becomes instantaneously worse. So what is the main derangement? The main derangement is chronic inflammation, and then if you have a pneumonia, some acute inflammation that adds up to increase the size of the wall of the bronchi and produces secretion. Both these mechanisms increases the airway resistance. Why? Because they decrease the radius, the size of the space free to airflow, passage of airflow. This is elevated at the fourth time in the equation to calculate resistance. And so even small decreases of the radius of the bronchi leads to severe, highly increased airway resistance. This is the numbers. Resistance is usually measured on a ventilator with the peak plateau difference and the flow. Usually at a constant flow, you can use 60 liters per minute, so the calculation is easier. And you see that COPD intubated has double the resistance of a RDS and maybe even 5 times the resistance of a normal subject. Increased resistance leads to increased time constant. What does it mean? That the time to deflate the system is longer. As Judy explained, the time is longer, so the next breath may start while the previous breath is still in the lungs. The gas in the lungs is higher than FRC, than resting condition. And this leads to gas trapping. Gas trapping leads to increased volume of air inside the lungs, increase the pressure inside the lungs chronically, which may lead to some remodeling of the lungs and to further emphysema, so destruction of the lung structure, that further increase compliance. And these
Tommaso, sorry,
yes.
sorry to interrupt you, but we only see the first slide. Probably you
so
have
it's not
to.
Moving on?
No, it's not moving from the first one.
Sorry, I go back because I'm at the 5th slide now. So let me see if I can share the whole screen. So now if I share like this, you see now the other slides?
Yes, now it's perfect. Thanks.
So let me recap briefly. This was the slide on the resistance, which is increased due to the decrease in the radius of the bronchi and elevated at the 4th time in the equation. This is the values for airway resistance in COPD as compared to RDS and to normal, so twice RDS and 5 times normals, okay? And this is the vicious circle of COPD that I was just explained, with the increase in time constant due to increase in airway resistance that leads to gas trapping because of the need of a longer expiratory time, to emphysema because of the remodeling, and to further increase in compliance that determines time constants as well. So this becomes a vicious circle. The more chronic, the longer the duration of the COPD, the more severe is the gas trapping and the difficulties in exhaling the tidal volume by the patient. Time constant is resistance times compliance, and this is why both increased resistance and increased compliance adds up to generate a longer time constant, to determine a longer time constant. And when the expiratory time is 3 times the times constant, 95% of the initial volume is exhaled. So if the time constant is higher because of higher resistance and higher compliance, the expiratory time of the patient needs to be longer. The problem is that when you have an acute exacerbation of COPD, you have shortness of breath, you have higher production of CO2 because you have fever, you have infection. So there is a conflict between the need to breathe more and the need to have a longer expiratory time. The respiratory rate is high, the expiratory time becomes short, the patient will need a longer expiratory time as compared to other patients, and this leads to a vicious circle determining gas trapping. Gas trapping was explained very well by Judith, so is the residual gas that remains within the lungs at the next breath. So you breathe, the next breath starts, and you still have part of the previous breath inside the lungs, so the next breath adds up to that, and the volume inside the lung grows. So you have gas trapping and intrinsic PEEP. This is a study showing that when you leave the same tidal volume, the white part, it doesn't change, but you increase the respiratory rate and you decrease the expiratory time, the lung volume at end expiration, this volume here, increases. So you have gas trapping. You have increased in lung volume because there is a obstruction to the expiratory flow. How to detect this at the bedside? So when you see a patient on controlled ventilation, here is the flow, here is the airway pressure, this is square flow, this is square flow, so this is volume controlled ventilation, and you see that at each breath, the expiratory flow doesn't reach 0 value before the next breath, here and here. So there is persistent flow at the beginning of the next breath. This is highly suspicious for gas trapping. And then you press an end expiratory occlusion, and the airway pressure goes up to the intrinsic PEEP. You see here, sometimes it's called auto-PEEP, sometimes it's called intrinsic PEEP. Intrinsic PEEP adds up to the set PEEP to generate the total PEEP. It's the difference between the total PEEP and the set PEEP. In this case, set PEEP was 0. So this is the true intrinsic PEEP of the patient that you see here is higher than 10 centimeters of water. So residual gas volume in the lungs generate positive pressure at end expiration, which is called intrinsic PEEP, that is the detection of gas trapping at the bedside if gas expiratory flow doesn't go to zero. Indeed, this has hemodynamic consequences, and the discovery, the first description of intrinsic PEEP in an intubated patient was done by John Marini, who was at the bedside of this intubated acute exacerbation COPD patient, who was deeply hypotensive. And I heard John explaining this. He couldn't explain exactly why this patient was so hypotensive. And then suddenly the nurse came, disconnected the patient for suctioning, and the blood pressure went up. So when the patient was disconnected from the ventilator, the hemodynamics effect were less evident. Why? Because the patient had a longer expiratory time because it was disconnected, and the gas trapping decreased, and the pressure inside the thorax decreases, and the venous return increased, and the blood pressure went up. So remember that the gas trapping has a consequence both on the lungs and on the heart. So when we have gas trapping, the problem is the expiratory time. So prolonging the expiratory time should be a key goal in setting the ventilator during controlled ventilation and assisted ventilation of intubated patient with acute exacerbation of COPD. If the intrinsic PEEP is due to the gas trapping, so dynamic hyperinflation, intrinsic PEEP will be added to the external PEEP. So if you increase external PEEP, you will increase the total PEEP if you don't change the expiratory time. So when we work on minimizing intrinsic PEEP due to gas trapping, dynamic hyperinflation, we should work on the expiratory time and not on the external PEEP. But there is also, and this is specific to COPD patient, is not common in asthma, and there is also another mechanism for intrinsic PEEP, which is a small airway collapse. So you see this scheme here. If you have a positive pressure around the lungs, which is increased because you have expiratory flow limitation because of the high expiratory resistance, at a certain point, the pressure within the bronchi will equilibrate with the pressure outside. If the bronchi is at the level where there is no ring outside keeping it open, so if it's collapsible, it will collapse. This will close small airways and lead to a different form of gas trapping, which is independent from the expiratory time. This is called critical pressure and leads to some volume of gas remaining in the lungs, but the compartment is closed, and even if you increase expiration to the infinite, you will never deflate that lung. You can see this on the expiratory flow shape that has two slopes, a first faster and then a slower, because at this point you lose a part of the airways that are exhaling the gas, and the gas remains inside. With the external PEEP, there is a huge difference between this gas trapping and the one due to dynamic hyperinflation, because if you increase external PEEP, until you reach the intrinsic PEEP of the patient behind the closed airways, the real PEEP of the patient will be the intrinsic PEEP. So the real PEEP of the patient is intrinsic PEEP until the external PEEP reaches the same level or passes it. Once it passes, the real PEEP is the external PEEP. So intrinsic PEEP due to a small airway collapse does not add to external PEEP. It's an independent function when it's an independent phenomenon, and when you put external PEEP, you will not modify the real PEEP of the patient until you crosses the value of the intrinsic PEEP. This is another representation of the same mechanism. You see that if you set PEEP, external PEEP at 0, at 5, at 10, there is correspondence between the ventilation of the patient and the set ventilation only when PEEP set on the ventilator is the same or higher of the intrinsic PEEP of the patient due to small airway collapse. This is another way to look at it, which I think at the bedside is easier to detect. You see here a patient on volume control, and you see here the peak pressure, and here the PEEP. You see that until this 1, 2, 3, 4th step of PEEP increase, there is no change in peak pressure, even though the tidal volume doesn't change. What does it mean? That here is the level where the external PEEP surpasses the intrinsic PEEP, and then peak will start increasing. So this is another way to detect intrinsic PEEP due to small airway collapse, the real intrinsic PEEP due to the pathological characteristic of the patient. This is another way to look at it. So as a study measuring end expiratory lung volume. End expiratory lung volume with the presence of intrinsic PEEP due to small airway collapse will increase only when PEEP crosses the intrinsic PEEP. And the hemodynamic consequence of PEEP, so the decrease in cardiac output, will be evident only when external PEEP crosses the intrinsic PEEP of the patient. This is another example that we published, is a decreasing PEEP trial. And you see here end expiratory lung volume measured with electrical impedance tomography. And you see that when PEEP falls below the intrinsic PEEP, which is around 8, so at step 6, 3, and 0, the end expiratory lung volume does not change, because even though you are changing the set PEEP, the real PEEP of the patient does not change, and the end expiratory lung volume remains the same. However, another step in the understanding the pathophysiology of this patient is to understand that auto-PEEP or intrinsic PEEP is regional, because the patient, especially during acute exacerbation where you have infection and edema, the weight of the lung, the regional weight of the lung is different. So the amount of gas trapping can be regionally distributed and unevenly. And we measured this with electrical impedance tomography. So with advanced monitoring or imaging monitoring, you can even detect regional auto-PEEP. And maybe if you have a region, because the one we see on the ventilator when we press the end expiratory button is an average intrinsic PEEP. But maybe we could target ventilation to the regional level, because one region could have lower, or one region could have higher than the average that we see on the monitor of the ventilator. So to conclude on the second part on intrinsic PEEP, is a different mechanism, is not dynamic hyperinflation, does not add up to the external PEEP. Real PEEP of the patient is the intrinsic PEEP. External PEEP is the real PEEP of the patient only when it crosses the value of intrinsic PEEP. And finally, if I have 5 more minutes, I would like to show the consequences of these two phenomena, both intrinsic PEEP due to dynamic hyperinflation and to small airway collapse, during assisted ventilation. These acute exacerbation COPD patients are usually old, elderly patients, and the clinical goal to switch them early after intubation to assisted ventilation, I think, is a key component of successful weaning, because you don't get muscle wasting, you don't get decreased muscular force. So we should try to switch them to pressure support we normally use, but we have to be aware that intrinsic PEEP is an additional workload for the patient. The gold standard to measure intrinsic PEEP during assisted ventilation is the esophageal pressure. The esophageal pressure swing from baseline to the start of inspiratory flow is the value of intrinsic PEEP. You see here in this case 6.3 centimeters of water. So the patient needs to generate 6.3 centimeters of water with his or her muscles before starting inspiration. This is a wasted part of the work of breathing that adds up to the work of breathing to breathe. So remember that when we switch them to assisted ventilation, they could have an additional workload to wean intrinsic PEEP. So at this point, one method to decrease the intrinsic PEEP and the additional workload by the patient is to add extrinsic PEEP. Why? Let's see this graph. This is a patient with 6 centimeters of water of intrinsic PEEP, and this is end expiration. There is no flow, intrinsic PEEP is 6, and external PEEP is 0. Then the patient generates 5 centimeters of water, so the alveolar pressure goes to 1 of inspiratory effort, but still there is no flow because outside the pressure is 0, so there is no difference of pressure and no flow between outside and the alveoli. And finally, the patient goes to -9, you have -3 in the alveoli, and you have flow. If you add an external PEEP of 4, just producing 5 centimeters of water will lead to an alveolar pressure of 1, and there will be a gradient now. You see here, with alveolar pressure 1, no gradient, no flow. With external PEEP of 4, there is a gradient, and there will be flow. So extrinsic PEEP reduces the wasted effort during assisted ventilation of a patient with intrinsic PEEP. However, precise measure of intrinsic PEEP during assisted ventilation is difficult because normally if the patient is dyspneic and has an acute exacerbation, will not relax during an end expiratory occlusion. So sometimes it's difficult to assess the presence of intrinsic PEEP during assisted ventilation. One key component may be to monitor effort. We should monitor effort at the bedside of this patient. The gold standard will be the esophageal pressure. We use a lot of esophageal pressure, and I invite everybody to try to use esophageal pressure. But there are other maybe simpler surrogates like PO1. PO1 is the pressure generated against an airway, occluded airway during the first 100 milliseconds. Is normally displayed by all the commercially available ventilators. And if you see a decrease in PO1 when you increase external PEEP, or if you see a decrease of the electrical activity of the diaphragm, which is another monitor of effort at the bedside, you will know that you may have reduced the amount of intrinsic PEEP, and maybe you can optimize external PEEP based on the minimal effort. So to conclude, during assisted ventilation, I would use a high support to increase the expiratory time, and I would use external PEEP around 80% of intrinsic PEEP to minimize the wasted work of breathing. So if I can summarize how to ventilate a patient with an acute severe COPD exacerbation. I will separate controlled ventilation from assisted ventilation, use controlled ventilation as short as possible, look at the expiratory flow if it goes to 0, measure intrinsic PEEP is easy here, you just press the end expiratory occlusion, increase as much as possible the expiratory time, use an external PEEP similar to intrinsic PEEP, just to know where you are, to understand the patient, or use a higher external PEEP if you need it for oxygenation. The patient can have COPD and ARDS, so sometimes could benefit from higher PEEP level. During assisted ventilation, I think it's crucial to monitor the patient effort, use the esophageal pressure, PO1, EDI, the tool you are familiar with at the bedside, and set an external PEEP to keep the effort within physiologic limits. PO1 between 2 and 4, EDI between around 10, 15, 20, there is discussion on this, delta esophageal pressure around 5, 8. Use eye supports to increase the expiratory time, but don't exceed the safety limits. Thank you.
Thank you, Tommaso. I think that was a fantastic lecture. I love it when people talk, respiratory physiology. It's really sexy. Anyway, Moving on, we have Sean Low. Sean is a fellow colleague of mine from Sing Health Duke NUS Lung Center. Sean is interesting because he's Singaporean, but he received his training in multiple places. He did his undergrad in Ireland, and then he moved to the United States, did his internal medicine residency at Pennsylvania, and then did his respiratory and critical care fellowship at Wake Forest Medical Center. So today he's going to share with us liberation from mechanical ventilation for COPD patients. And after his talk, we will sort of move on to some questions and answers. So Sean, take it away, please.
All right, thank you, Melvin. So I'm Sean Low from Singapore, and my topic today is on liberation from mechanical ventilation for COPD patients. I'd like to thank the organizers for putting together such a fantastic program for today. So the problem with this is that for many of COPD patients, more than half of the mechanical ventilation time is spent during the weaning process, and they have a high mortality where 1 in 5 do not survive hospital discharge, and close to 50% of them do not make it at 1 year. So reintubation is another problem because it occurs in 6 to 23% on average within 2 to 3 days after a planned extubation. There are multiple causes of respiratory failure after extubation, including upper airway obstruction, inadequate cough, excess secretions, cardiac dysfunction, neurologic impairment, older age, increased severity of illness, longer duration of ventilation before they get extubated, anemia, and continuous sedation. So in this paper in 2017, multiple factors were found to be associated with weaning failure. So in order of prevalence, malnutrition, electrolyte imbalance, myocardial ischemia, hypothyroidism, delirium, overfeeding, and in about 5% of cases in this cohort, no risk factor was found. So to start with, for the first problem of malnutrition, when they compared the failed weaning group with the successful weaning group, 63% of them were found in the failed weaning group compared to 40%. So this can limit muscle mass and capacity of contraction. Overfeeding was also an important cause of weaning failure in other studies, with an increase in daily caloric intake, leading to a rise in metabolic carbon dioxide production. Secondly, delirium is also common, where 20% in the failed weaning group was found to have delirium compared to 0 in patients who are successfully weaned. Other studies found impaired cognitive function was associated with a fourfold higher risk of failed extubation. So new ischemic changes in failed weaning group was found in about 35% of patients, where recent myocardial ischemia was associated with failed weaning. This occurs due to a rise in global and myocardial oxygen demand during the weaning process. So this can unmask any unrecognized myocardial dysfunction at the start of weaning attempt. The next variable which can be used would be the maximum negative pressure, the MIP, generated when there is temporary occlusion of the airway. For this, there is conflicting evidence where multiple studies showed no significant difference, but in one study, there was a significantly higher negative value in the success group compared to those who failed weaning. There's also a gray area between 20 to 30 for MIP, where it cannot predict reliably the weaning outcome. And so this value can also be related to difficulty incorporating when doing this maneuver. Other factors which can affect this value would be if there's excessive respiratory loads. Even a normal muscle with normal MIP will fatigue if it's coupled with excess loads. The P 0.1 represents the drop in pressure airway during the first 100 milliseconds of inspiratory effort, just like what Tommaso discussed earlier on. So this represents the mechanical index of respiratory drive, and it's a measurement of intensity of the stimuli from neurologic centers to the peripheral muscles. This is effort independent and is mainly affected by impaired neurologic drive. So in the previous study that we looked at before, so there were no significant differences between the two groups for P0.1. But an earlier study by Neil McIntyre found that a value less than 4.5 is associated with high weaning success. What about the rapid shallow breathing index, which is commonly used to assess patients when they are ready for extubation? So in the previous study, they found that there was no significant difference in the RSBI between the two groups, which was consistent in multiple studies. But when the earlier study looked at it in categories, they found that a lower RSBI cutoff of 85 was associated with a higher weaning success. This is another study that looked at the RSBI cutoff, and these patients were COPD patients with hypercapnic respiratory failure in a prospective observational multi-center study. They checked the RSBI 120 minutes after an SPT and found that 48% of patients were successfully extubated in this study. They found that the point of optimal performance was less than 85 with an area under curve of 0.9, suggesting that the traditionally used RSBI threshold of less than 105 may not be appropriate for COPD patients on ventilation. Next, we move on and look at the coexistence and impact of limb, muscle, and diaphragm weakness, the time of liberation from ventilation in ICU patients. So here we see that ICU-acquired weakness was defined by a physiotherapist assessment with MRC score less than 48. And diaphragm dysfunction is a pressure less than 11 in the endotracheal tube pressure after phrenic nerve stimulation when the airway is occluded. So here we see that patients with ICU diaphragm dysfunction, about 42% of them did not have any ICU-acquired weakness. And when we look on at the outcomes of these patients, we see that patients who had diaphragm dysfunction, about 48% of them had difficulty weaning. And in the patients who had difficulty weaning, about 92% had diaphragm dysfunction. So in the patients who had diaphragm dysfunction, we see that 21% of them had COPD. But for the patients who had COPD, about 83% of them had diaphragm dysfunction. So this problem is quite prevalent in our COPD patients. This was another interesting study that looked at the evolution of diaphragm thickness when patients are started on mechanical ventilation. They looked at outcomes at 8 days. So here they found that these patients were divided into 3 groups at the end of 8 days. So 44% of them had less than 10% change in the diaphragm thickness at the end of 8 days. About 44% of them followed this trajectory with greater than 10% loss. And about 12% of patients, they had greater than 10% gain before day 8. This is important because a less than 10% change in diaphragm thickness is associated with an increased chance of liberation and better survival. And when we looked at the duration of ventilation, compared to the change in diaphragm thickness and also the change in the mean diaphragm thickening fraction over the first 3 days of ventilation, we find that the lowest duration of ventilation is associated with those with less than 10% change in diaphragm thickness, as well as this sweet spot of 20-25% diaphragm thickening fraction. So how do they achieve this? They looked at the average ventilator driving pressure over the first 72 hours of ventilation, and they find that patients with a higher mean driving pressure was associated with greater than 10% loss, while the lowest mean driving pressure was associated with greater than 10% gain. So there is this sweet spot where titrating the ventilatory support to maintain some adequate level of diaphragm activity is important to prevent changes in diaphragm configuration. Otherwise, they called it the muscle protective ventilation. So now we switch gears and look at other parameters that can be useful. So this study looked at diaphragm rapid shallow breathing index and predicting outcomes in patients admitted for acute exacerbation of COPD. So this was a prospective observational study in ready to wean COPD patients. And so they were put on T-tube SPT and looked at ultrasound assessment of the right diaphragm displacement, and then put them on N mode to calculate the DRSBI. And they use a 3.5 megahertz ultrasound probe in one of the lower intercostal muscles on the right anterior axillary line. And they measured the diaphragm displacement from the end of expiration to the end of inspiration. So they followed the outcomes of these patients and found that about 3/4 of them were successfully liberated. About 13% of them failed the weaning trial, and 62% needed to be reconnected to a ventilator. About 15% of them had to be reintubated within 48 hours of extubation, and 23% of them required NIV support within 48 hours. And when they compared the two groups between those who were successfully weaned versus those who failed weaning, we find that the patients in the weaning success group, they had a higher mean diaphragm displacement and also a lower DRSBI value compared to those who failed weaning. And to look at the cutoff values, they found that a diaphragm displacement less than 12 has a high accuracy in predicting, let's turn this off. So diaphragm displacement less than 12 has a high accuracy in predicting weaning failure, as well as a DRSBI value greater than 1.9. So the rationale is that diaphragm displacement reflects more closely to diaphragm function compared to tidal volume, which is used in calculation of the RSBI. Therefore, in the presence of diaphragm dysfunction, accessory muscles of inspiration, they play a greater role in generating the tidal volume, but this only lasts for a short period of time, and these muscles end up to be tired after a while. So tidal volumes are less linked to the function of diaphragm compared to diaphragm displacement, which reflects the ability of the diaphragm to generate an inspiratory volume. Next, DRSBI reflects not only a diaphragm function, but also the presence of rapid shallow breathing. And this reflects the balance between the respiratory load and the ability to face it when you subject the patient to an SPT. This study looked at the role of budesonide, which is commonly given in COPD patients. So the group studied 55 difficult to wean COPD patients with very severe airflow obstruction who had previously failed at least 3 SPTs. And these patients were treated from the time of admission with oral prednisolone, 30 milligrams once daily. And randomly, these patients were assigned to inhale budesonide versus placebo. They looked at the cytokine levels for these patients, and they found that these levels were elevated in patients compared to healthy controls, but decreased over time. Also, when they looked at the dynamic compliance of these patients, it was improved in the budesonide group over the control group, as well as the pressure support across 5 days. The days of mechanical ventilation, as well as ICU days and reintubation, was significantly lower in the budesonide group. Therefore, in this study, they concluded that the benefits of inhaled therapy is achieved despite background therapy, even with systemic steroids, because these were able to reach receptors which were not accessible by systemic corticosteroids, and they were able to achieve higher local concentrations. So this is the official ERS ATS guidelines for NIV for acute respiratory failure. So the first question is, should NIV be used to prevent respiratory failure post-extubation? This was a study looking at extubation in high-risk patients, which was defined as hypercapnia, congestive heart failure, weak cough, excessive secretions, stridor, greater than 1 weaning failure, and greater than 1 comorbid condition. And these patients had more than 2 days of ventilation, and these patients were randomized to NIV for 8 hours or more in the first 2 days versus oxygen therapy. Here we see that about 1/3 of the patients were admitted due to COPD exacerbation. When we look at the outcomes of these patients, I'd like to draw your attention to the outcomes here in the multivariate analysis. We found that the patients who were on the NIV they had decreased rates of reintubation compared to those on the oxygen-only arm. So they concluded that the prophylactic NIV applied for at least 8 hours a day during the first 2 days significantly reduced the rate of reintubation. In the next study, this was also patients at high risk of extubation failure, which was defined by age 1 and 65, cardiac failure as the cause of intubation, and a high sickness severity score. And these patients were randomized to 2 arms with near continuous NIV for 24 hours or oxygen therapy. So here we see that the patients in the NIV group, they had lower rates of respiratory failure after extubation, as well as significantly reduced ICU mortality compared to the control group. When they looked at the 90-day survival, there's no significant difference between the 2 groups. But when they did a post-hoc analysis, they found that patients who were hypercapnic, they had better survival compared to those in the control arm. And when they looked at patients with hypocapnia, the ICU mortality, hospital mortality was significantly reduced in the NIV group. And so they concluded that NIV for 24 hours after extubation improved hospital and 90-day survival in those with hypocapnia during SBT. So the recommendations would be to apply NIV immediately after extubation because a longer time from extubation to reintubation was associated with worse outcome. So a delay in reintubation correlates with worse survival in patients who receive NIV. And so early application of NIV is crucial to avoid respiratory failure. So what's defined as high-risk patients is quite inconsistent. In this study, which is highlighted below here in 2011, they looked at patients greater than 65 years with underlying cardiac or respiratory disease. And so the cardiac diseases included a poor EF, less than 45%, ischemic heart disease, atrial fibrillation, and severe valvulopathy. Chronic lung diseases included COPD, OHS, or any restrictive lung disease. So if patients had 2 comorbidities, the reintubation rate is more than 30% compared to those if only one of the 2 is present. The next question is, should NIV be used to facilitate weaning patients from invasive ventilation? There were 16 RCTs that looked at it, of which 9 of them exclusively looked at patients with COPD. 6 were mixed populations. And so here we see that patients, if they were put on NIV as weaning, this was associated with significantly decreased mortality. And also there's significant reduction in weaning failure in patients who were put on NIV. If we look at the largest multi-center RCT with over 200 patients who were ventilated for more than 2 days, these patients needed to have known or suspected chronic hypercapnic respiratory failure based on their history, so COPD, asthma, bronchiectasis, OHS, or any chest wall deformity or previous TB. When these patients had SBT intolerance, they were randomized into 3 groups. So conventional weaning through the endotracheal tube, early extubation followed by NIV, early extubation followed by oxygen therapy. So for both the oxygen therapy and NIV groups, the SBT failure, these patients were reconnected to the vent for more than 30 minutes, followed by extubation to either standard oxygen or NIV. NIV was applied for a daily duration of 6 hours or more. Then it was switched to oxygen. Rescue NIV was used when there's post-extubation respiratory failure in both of these arms. In terms of outcomes, we see that the patients who are in the NIV group on the right side here, they had a significantly reduced rate of post-extubation respiratory failure, reintubation, or death compared to the oxygen or invasive weaning group. And this also includes patients who were put on rescue NIV. So in summary, for this guidelines, the committee recommends conditionally that NIV be used for post-extubation in high-risk patients for prophylaxis, as well as weaning in hypercapnic patients. But there's a conditional recommendation against it to be used for post-extubation respiratory failure. So coming to the end of the talk, and these are some newer studies that has been out recently. So the use of high flow nasal cannula versus NIV in facilitating weaning. So they found that there's no significant difference between the two groups, and the p-value was 0.6, even though numerically the NIV group had lower rates of treatment failure, they had lower rates of reintubation rates, but this was not significant. But for the high flow nasal cannula group, the comfort scores were higher and fewer patients needed bronchoscopy for secretion management. These are some trials which were out recently but not discussed because these were not predominantly patients with COPD in these trials. So these trials include a brief study as well as the high wean randomized clinical trial. Other studies which are up and coming would be the use of inspiratory muscle training to improve weaning outcomes in difficult to wean patients. And so this is ongoing. So in conclusion, liberation from mechanical ventilation in COPD patients, the A to I approach. So to start with, for A would be to optimize inhaled steroids and bronchodilators. And the use of inhaled steroids have additional benefits on top of systemic steroids. B would be for the brain to screen for delirium, to minimize continuous sedation. C for cardiac to screen for any cardiac dysfunction, myocardial ischemia. D, because diaphragm dysfunction is very common in difficult weaning patients. And so the use of ultrasound to see whether there's a less than 12 millimeter diaphragmatic displacement or DRSBI greater than 1.9, high weaning failure rates. And we might want to consider reducing the RSBI cutoff to less than 85. Other things would be to avoid too high or low driving pressures. E is for endocrine to optimize thyroid function. P for feeding, F for feeding, optimize nutrition. G for good lung recovery, and once the acute disease process such as pneumonia has resolved. H for high-risk extubation in hypercapnic patients. So after extubation, prophylactic immediate NIV for 1 to 2 days in high-risk patients, but limited role in low-risk normocapnic patients. And the use of NIV in weaning for SPT intolerant patients, lower rates of post-extubation failure, reintubation, and death. And I tried to include this in for inspiratory muscle training and the role of high-flow nasal cannula in these patients needs further study. Okay, so just some concluding slides. So this was our World COPD Day, where we went out to the community, to 2 shopping malls to spread the word about COPD and the detrimental impact of smoking. And then I'd like to thank the organizers and the attendees for your support. And this is from us in Singapore. And I'd like to invite everyone to attend our 7th SGN6 conference next year, 2nd to 6th April in Suntec City, Singapore. Thanks, everyone.
Thank you, Sean. So we have come to the end of the session. So we are running out of time. So we've got about 10 minutes or so, and I think Dr. Tommaso needs to leave quite promptly. So we have got some questions from this Dr. Francesca Rubilota. So I'll just ask on her behalf first to Tommaso. I think she wants to ask a question to know if it's expensive or time-consuming using regional strategies to target ventilation, and if this could reduce the length of stay and save money.
Okay, so the technology is there. It depends what you mean with expensive. Sure, it's not for research limited settings, but I think Francesca works in UK, so it should not be that expensive for them. I think it's where we are going. So targeting global values of lung physiology is not ideal. Ideal is to target regional values. So we need some regional information. CT scan is a way to detect these heterogeneities, and it's not expensive, it's there. However, it's time consuming and risky for the patient. So I hope that more technologies will be cheaper and like the smartphones and becomes available at the bedside, because we need to arrive there. I don't think it's a matter of how much it is. I think it's the way we will improve our practice. So we should aim to that.
Okay, and I think we have another question for you from Egypt. I think the question is, what is the alternative mechanism for intrinsic PEEP?
Okay, so in the two mechanisms, one is dynamic hyperinflation, that the lung does not deflate enough when the next breath starts. This is number one. Number two is small airway collapse, that you have some collapse of airways that limits the expiratory flow and will retain gas behind them. And this is not modifiable, is not influenced by the expiratory time. This is the main difference in the ventilator.
Yep, I think that's really a good answer. Yeah, so I think for the this person from Egypt, yeah, I think it's got something to do with closing capacity and the FRC of the patient, especially in long-term obstructive lung disease. And I think, thank you, Tommaso. If you need to leave, I think you can. Judith, I've got a question from you for you as well from Francesca, and she wants to ask you for the basic ventilator parameters that you suggested. Is it applicable to all? Should it be applying to all asthmatic patients or those who have already developed some form of dynamic hyperinflation?
I'd be using those ventilator parameters with any intubated asthmatic patient because you're trying to avoid the development of dynamic hyperinflation. So those are my starting parameters for anyone. Yeah, I agree. I would use those as well for all asthmatic patients. Yeah. Okay, for Sean, I think yours is quite a difficult topic. So I'm just wondering from a respiratory physician's point of view, you talk about all this predictors of, poor weaning. But, a lot of patients who, with COPD exacerbations, even they fail SBT, we extubate them to NIV. So what's your take on, on this? Like, that we have to go through the entire rigmarole, and then, when I'm just going to extubate them NIV anyway. Yeah.
As you can see, it's a very difficult problem because I tried to come up from A to I, but I'm sure there are multiple other factors beyond that from A to Z, which we cannot really cover because it's such a multifactorial difficulty for these patients. Like many of them have worsening muscle weakness, and I found that the study of diaphragm dysfunction associated with limb weakness, so there's no real correlation between the two. And so I think there's under recognition of patients with diaphragm dysfunction, and it's something where I think considering the role of inspiratory muscle training, whether it has any additional benefits. And also I think optimization of bronchodilators for these patients on COPD, optimization of long-acting bronchodilators for these patients may also help in a certain extent. But I think overall, it's really like discussion of whether these patients really should go on the ventilator in the first place because we know that many of them have many comorbidities, and like each day on the ventilator can be quite detrimental for them.
Yep. Yeah. Thank you. So, to the moderator, so we have to stop. It's already.
Okay. Thank you.
Okay. Thanks, everyone.
Thanks very much.
Thanks, everyone. It was really fun.
Great.
Okay. Yeah. I want your slides. Yeah. Thank you. Bye.
Hey, ciao. Adios.
Ciao.
Good night.